Welcome everybody to our Rise Lunchtime webinar. Today we're having a discussion about how we can take steps as Ontario Health teams toward collaborative governance. And as I mentioned, I'm Heather Bullock. I'm the executive lead for Rise, and today I will be joined by Anne Corbett, who is a partner with BLG, who's an expert in collaborative governance, and also Terry Sparling, who is from the Huron-Perth area OHT, and she is the CEO of her Huron-Perth Centre for Children and Youth. So that's exciting to have a child and youth expert with us as well. So I just wanted to remind everybody that this is the last in the series of scheduled webinars that we have for this phase. That's the phase prior to the full application deadline of October 9th. We are currently planning our next suite of activities and resources to support OHTs. So if you have ideas, feel free to email us or post your suggestions in our OHT community practice, and we will happily integrate them into our next set of activities and resources. Also, just a reminding, a recording of today's webinar will be posted on the RISE website under Join Events, and actually been quite heartened to see how many people are accessing those recordings on their own time if they were unable to connect during lunch. So that's helpful to have that after the fact as well, or if you want to go back and listen to a certain component of it again. So this is a key, collaborative governance is a key element of Ontario Health teams, and that's reflected in the full application. So in sections 4.1 and 4.2 in particular are around trying to understand from teams whether they share common goals, values, and practices, and then also what they're proposing in terms of governance and leadership structures moving forward. And they've teased that out to say, you know, how are you planning to govern and make shared decisions? How will you manage as a group? What is your plan for incorporating patients, families, and caregivers into leadership and governance structures? Because that's a critical element as well. And then finally, what's your plan for engaging physicians and clinicians and clinical leads in your team membership and leadership as part of the proposed governance structure? So there's quite a bit of emphasis in the full application on collaborative governance, and that's why we wanted to conclude this part of our RISE webinar series with this important topic. Just for your information and background, when we talk about collaborative governance, we're really talking about a governing arrangement where leaders from organizations, in this case drawn from multiple sectors, engage in a collective decision-making process, and that process is deliberative, consensus-oriented, and directed to the achievement of a shared goal. And if you'll recall, the shared goal for OHTs is the quadruple aim. There are three possible steps toward collaborative governance in the first year of an OHT's operation. The first would be to establish a written agreement addressing decision-making, conflict resolution, performance management, info sharing, and resource allocation. The second would be making board-level decisions that position partner organizations to learn and rapidly improve to contribute to the Ontario Health team efforts. And then the third is to organize cross-board processes and cross-organization processes more generally that build trusted relationships amongst partners. And you'll recall trusted relationships, I think, is a critical foundation to the OHT being effective at maturity. If you're not operating from a foundation of trust, it's very difficult to make headway later on in some of the harder decisions that OHTs are going to encounter in their journeys. Even though we're not focusing on this aspect of collaborative governance in our webinar today, I just wanted to spend a moment to talk about primary care leadership and engagement. And it's really critical to have primary care providers understand the OHTs, but also be engaged in all aspects of the decision-making and leadership capacities. And we have organizations within the province who are there to help OHTs to connect with their membership. So the Ontario College of Family Physicians, the OMA, the Registered Nurses Associations of Ontario, and the various associations representing community health centers, family health teams, et cetera. You can see a big list there of acronyms. Anne and I were just joking about all the acronyms in health. And outreach through the networks. It's important to support primary care providers to become leaders in their OHTs and help shape it. And there already have been some resources generated by those partnering associations to help OHTs start to think through this. And we've been in discussions with many of them about a next suite of resources that can help OHTs on this journey around engaging primary care and ensuring that they are active members in OHTs as well as leaders. Again, we just highlight here that trusted relationships are key. And in the OHT's first year of operation, or the foundational work that they've been doing to date, it's really about developing that trust, and that's really going to go a long way moving forward. So I'm going to stop there and pass the mic over to Anne Corbett, who's a partner at Borden Ladner and Gervais. She is generously agreed to participate as a key panelist today. Once she's finished with her information and principles around collaborative governance from her perspective, we'll be passing the torch over to Terry Sparling, as I mentioned, and I'll introduce her again as we get to that section. So without further ado, Anne, I'll pass this over to you.
Great. Thank you very much, Heather. And it's a pleasure to have the opportunity to be with you all today and to share some perspectives around OHT formation. I want to begin by speaking to provide a little bit of context and particularly around a system perspective, some of the questions and challenges I see boards have and organizations have between our acting in the best interest of our own organization and now this expanded sense of a collective mission. Requirements for the OHT at year one and at maturity, but more importantly, some of the considerations for year one decision making, particularly with reference to the requirements not only of the full application, but some of the work we're seeing that's been emerging around the province, around some of the formation of the first year OHT decision making frameworks. So these are some key principles or key success factors. I struggled with what to call these points, actually underlying premises or assumptions, but they're just some foundational principles, I think, that it's particularly important that OHT participants share these. I think that will be key to future success and to building a platform of a strong decision-making platform for year one that can eventually evolve to an at maturity state. And the first one I think we should never forget, which is that in our province, we continue to recognize the value of local, voluntary, independent governance, and that it continues to be important in our healthcare system right across all of the various sectors of healthcare providers. And my own experience working with volunteer boards over the years is that I believe they do play a very valuable and important role. They connect the organization to citizens locally, and they have an opportunity to advocate on behalf of their health provider, and now an opportunity to work with other health providers. One of the key things I think that's been important in the continuing recognition of local voluntary governance is the quality of that governance. And we have seen health provider boards continue to invest in the quality of their own governance, and I think that will be important going forward. I think good governance is also an important success factor for OHT work. My own experience is that organizations have high governance or speak the same governance language, they come together more easily. And so while we're in this evolutionary state, I think it's important for boards to continue to invest in the quality of their own governance, and to do that where they can on a board-to-board basis. It's an opportunity to help build trust, but also to share common approaches to governance across organizations. The third thing I've listed here is with respect to the shared vision, a shared belief that quality, accessible, affordable health care requires a health system approach, and that the health system will be strengthened by breaking down silos and providing integrated care. We know that's at the heart of the reports around hallway medicine. And if we look at our healthcare system, if we do any kind of historic look back, you'll see we built it in waves, starting with the Canada Health Act and hospitals and physician services being publicly funded, but then adding in things like community health, home care, primary care, family health teams. And we have an opportunity now to provide for more integration of the delivery of healthcare services. But boards, in my experience, struggle with that, with the duty they have to their own organization and the duty to the system as a whole. You will be asked that question, some of you in your boardrooms, by directors. How do I reconcile the duty to this entity with the duty to an Ontario health team? And I think it's helpful when boards spend some time talking about the fact that they very much have a shared mission. And that shared mission is for the healthcare of the community generally. And there are also shared accountabilities in the health system. So taking that broader system perspective, sometimes pulling back and saying, why does our mission matter? Why do we do what we do? Helps get boards and organizations to a point where they start from the same perspective, which is a healthier community and limited resources being used to provide the greatest benefit to our communities. So I'll talk a little bit more about accountability, but on this point, I do want to say that the duty of the directors, and this is why they will struggle with it, is to make decisions that are honest, to act honestly in good faith and in the best interest of the corporation that they serve. And that requires, of course, some definition of what best interest means. And in mission-driven, not-for-profit corporations, that will mean furthering the mission and discharging accountabilities. And so that's shared across all mission-driven, not-for-profit corporations, and spending some time talking about what that mission is and what the accountabilities are will, I think, get organizations closer to a shared sense of mission and accountabilities. The fourth point I'm making in boardrooms when I have the opportunity to speak to them is to get comfortable with ambiguity. There just will not be some answers to some things, particularly in the early years. And I came to that as an important point to share when I got questions about creating a single corporation. So I think those who were not as close to some of the early work around OHTs assumed that where we were going to was to almost immediately to a single governance entity and extensive due diligence. And this is not about governance integration. I think it's pretty clear that initially, and maybe even at maturity, current boards and funding will remain in place. Funding will remain in place initially for sure, and current boards will remain in place. So this is not governance integration, it's system integration, it's patient care integration, client care integration. I think we also want to be careful about the language we use. I tend to default to patient, but I know for some of the sectors it's clients, and in long-term care we speak about residents. So just to bring forward, when you do struggle with that concept of letting go a little bit, that's the other message I'm giving is to boards, is that this may involve some letting go, doing less so that the system as a whole does more. We talk about this accountability to the system as a whole. So just demonstrating here that all of those multiple accountabilities, you can sit there putting yourself in the center of this, whatever organization you might be, and see how you share that accountability. We also have to remember that for some of the participants in OHTs, they will have funders other than Ontario Health or the LHINs, and we have to be mindful of that. So also, kind of another tip I'm getting is in these early days, the more you can learn about other health providers and the more your boards can learn about other health providers, how they're funded, the scope of services and programs, I think that's going to be also a key success factor for future integration. So we have on the one side of the page in the lower left corner, I've got mission, vision, values, and accountabilities. And then I think we also share these other governance principles, decision-making principles that apply in a not-for-profit, a publicly funded system of patient client-centered focus, engagement with the communities we serve and with other providers, engagement to ensure we enrich the quality of the decisions we make, accountability, demonstrating accountability for public funds, and demonstrating value for money. And then I've just brought forward that statutory obligation, which I think the OHTs provide not only an opportunity, but we always have to remember that we've had this obligation. It was in the Local Health System Integration Act, and the language has been brought forward almost identically, but adding the Ontario Health Team. So that's the mandate we all have, if we're subject to that legislation, to be looking for opportunities to integrate the local health system. So let's move now to the implications of being an Ontario Health Team and what we're seeing in terms of structures potentially at maturity and certainly in year one. The Connecting Care Act does not prescribe a governance model, and the government's been very clear that there is no one model, that they are to be fit for purpose. The very definition of an integrated care delivery system suggests that it could be a group of persons or entities, not necessarily a single entity, and of course we know that it will be providing these services. What's the implication of being an Ontario Health Team under the Act? Because I think sometimes that gets missed. We're all on this sort of train leaving the station to form it, but what will be the long-term implications of that, and we know it's a single funding and accountability framework. It could potentially be subject to integration orders, so treated like a health service provider is now under the Act, which means there could be an integration to acquire a service, to divest a service to another OHT, to require an entity to become a participant in an OHT, subject to the oversight, which you would expect spending public funds, that there would be the typical oversight around directives, audits, reviews, investigators or supervisors, but it could also be subject to a transfer order under Part 5 of the Connecting Care Act. And those are the provisions that will enable assets and programs from the LHIN to be transferred out, potentially to an OHT or a participant in an OHT. So that's a potential for how home care may be dealt with in the future. And that's another implication of being an Ontario Health Team. So just some bringing forward, just again, foundationally, as we look at year one formation, this is me speaking now, but what I take from the ministry's materials is that the focus is to be on improving patient-client care and building trusting relationships. In fact, I believe that when if we look at those when I look at the year one target populations that some of the OHTs I've been working with have identified, and the methods they're beginning to talk about to achieve that improvement in patient care in year one, if they're successful, I think it's inevitable that the building trusting relationships will be the byproduct of that. And that will facilitate and enable the identification of year two targets, and that will enhance trust again. So I think that should be the priority, and that's been pretty clear in the materials that we've seen, a common understanding of patient needs. And no organization should take over other providers, but for some groups, a lead organization might make sense. But there's not really a prescribed role for a lead organization, and I'm seeing different OHTs approach that differently. I think the one need that's been seen is there might be a role for someone to hold funds if there's a decision to pool or transfer funds, but more as an agent or as an administrator. So not a lead in the sense of one organization having any dominant decision-making role. In fact, I'm seeing the OHTs come together very much as equal partners, regardless of the size of the organization or the resources and employees of the entity coming to the table. And then I've just brought forward some of the key things I think that impact how governance gets structured, governance or decision-making models, that there's no specific models. OHTs are free to determine the model that works for them, to be self-determined and fit for purpose, that there is a need for patients, families, and caregivers to be involved, and you'll see how we have a vision for how that might happen. And then that a need for physician and clinical engagement plan. Physician participation is voluntary, but the vision is for physicians to play leadership roles, function as core members of the team. So I won't spend too much time on this slide because Heather already addressed some of the things that we want to have in that written agreement between the team members themselves. So one of the requirements will be not only an agreement between the ministry and the team members, but the team members would have a written agreement around their own decision-making, conflict resolution, performance management, information sharing, and resource allocation, and that the model that's developed must enable this list of things, and you've probably read this more than once in your application processes, but I think what's important is that while the model must enable this, and some of this you're to report on at the end of year one, as I read the application and the materials the ministry has issued, I think there's probably different OHTs will move forward on this at different stages. I think these are important, though, because many of these relate to an end state, the strong financial management and controllership, the ability to work towards a single clinical and fiscal accountability framework, a plan or process to phase in the full continuum of care. So even though we be starting with target populations that may not include the broader geographic area, I think it's important to always have in mind that we need to think about where we want to go when we're starting so that we create a strong foundation that will enable those eventual goals of our at maturity OHT. So the last bit of context before we get looking into some models. So while it could be a single entity under the legislation if it provided 3 or more services, we think it's more likely to include more than one entity, and governance contractual relationships amongst the team members will be required. I think not only initially, but I think at maturity that's likely to be the model for a number of reasons. Remember, year one, we're focused on our service of clinical integration, not governance integration. And I think I know in some boardrooms when I made that comment, you could feel the temperature go down a little bit, particularly initially. I think people now have a pretty good understanding of what it looks like, but I think there was a thinking that this would be quite a disruption to board governance. And what we see in the early years is that boards may not have a very strong role, that these are being largely management-led, not surprisingly, because we're talking about operational client-patient care integration, and that is something that would normally be led at the CEO, executive, or senior team level. I think even in year one and at maturity, the agreements around OHT formation will continue to fit along a continuum of formality. I mentioned to get boards to get level comfortable with some uncertainty and ambiguity, but we're seeing common challenges and questions emerged, and we don't have answers to all of these yet. I think there'll be no doubt shared learnings from around the province around some of them, but how to engage primary care. I think the important thing is that everybody is asking that question, so it suggests to me that that's identified as key to the success of Ontario health teams. But where's the voice and how do we get it at the decision-making table? How to engage with regional resources and specialty facilities. We're seeing participation in more than one OHT by some entities. When will funding change? I get that question a lot. How will funding be designed? Will there be risk and gain share? How will surplus be handled, et cetera? So there's lots of curiosity about the state we're going to. Some of those questions I think are more pressing in year one than others. And the others, we're sort of saying wait and see, that they don't impact how you design your OHT for year one, and I think that's important. So we've identified what we consider to be some building blocks within OHT. And initially, if some of you looked at our earlier publication back in April, we actually thought of this as a continuum of formation. We've evolved our thinking a bit. I think what we feel now is that at maturity, these legal relationships may all fall within an Ontario health team, and I'm underscoring the word team in team, that you can have a player in your team that's in another team. You could have someone you consider part of the team for things like strategic planning, but they may be in a service provider contracting arrangement in terms of service delivery. So working together is what we have had in the past largely, although sometimes we moved into some of the more formal arrangements. But I think bundled care programs, their genesis was largely an organization sitting down and trying to identify how they could work better together. Home care has always been part of the system through service provider agreements, and that may continue. Collaboration arrangements, that's where we are now. That's what I'm seeing is the structure being used for the formation of the year one decision-making tables. And it's also the way I think bundled care has been given life to. So collaboration agreements, some are calling them joint venture agreements, we're using the word governance agreement for some, but we shied away from that because it suggests more of an intermingling of legal entities than what's actually happening. Organizational alliances, my yellow box there, those are more formal. Those are situations where there is some shared governance, so we're not seeing that as a model now, although we did have some discussions about that. But that's where boards would delegate board-level authority to a joint board decision-making table with representatives of more than one entity. I think it might have a role in the at maturity state. And then single corporations, likely this may evolve to a single entity to hold the funding envelope, but there could be single entities within the OHT team. So the at maturity vision, and I share this because I talk to some groups that say, I need to know where I might end up to know how to start, and others who say, don't show me that, just tell me how to begin. So for people who come at this from those two directions, we'll start with the end state and then go back and spend more time on how we begin. So I think the most important thing on this slide, from my perspective, is what's in the dotted rectangle at the top and at the bottom. So we know that the eventual end state will be a single funding and accountability framework to ensure, what's at the bottom, the full continuum of services being provided in a coordinated and integrated manner. That patients, clients, and residents won't know where they get their services from. They'll only know they get them in the full and continuous way. And as between Ontario Health and the team as a whole, there'll be a single funding envelope and a single accountability framework. And then the recipient of that funding envelope, the sort of holder, which I've called the OHT governing entity here in the red box, will be accountable to ensure that within the team, there is consistency around the strategic plan, the deliverables, that the funding is allocated to achieve that end vision. And that will require, I think, that governing entity to have attributes that will ensure stability, that the organizations that are part of the team that enter into accountability or funding relationships or participate in the overall strategic plan will have confidence in the decision and leadership getting made at that table. So we'll have conversations about that as we evolve through this, but you can see the various relationships. There may be services provided directly or through a subsidiary where there's governance control, the red boxes. There may be an independent corporation with a service accountability, somewhat like the kind of arrangements that exist between LHINs and service providers, the service provider agreements, or the joint executive committee. And the example I use in the yellow box on the side is eventually if there's development of supportive housing, you may partner with local government and there may be shared governing arrangements. But what we're seeing for year one, and I'll move ahead now to the next slide, which shows the year one vision, because I've talked about the models. It looks a bit like this. So the purple box in the center is the decision-making table, some kind of committee structure. It might be called a joint venture steering committee, a collaboration committee, a collaborative committee. Well, it could be a newly incorporated corporation with a governing board. I'm not seeing that, but some may be moving to that model. Certainly these sort of collaborative decision-making tables are more common. So team members with representation, you can see the patient's clients with input or decision-making, primary care with input or decision-making, physician leadership. Off to the left in the deeper blue circle, input and engagement with future team members, partners, supporters, the larger community. You might have some of the volunteer sector there if they're not otherwise on the team. Admin support to support the work of the team, so parties have to figure out how they're going to share their resources to source that. And then a number of subcommittees, and the subcommittees are going to provide the opportunity for the future team members to participate at that level. If there's a future governance committee, there might be an opportunity for board participation. A subcommittee might be a board engagement committee that has or chairs council that permits engagement. And as projects are developed and identified, there may be a need to have specific legal contractual arrangements or memorandums of understanding, and that's where you will do your due diligence around human resources, a business plan, any fiscal resources that are being shared, seconded employees, defining deliverables, measurements, so you can determine whether or not progress has been made. So common issues, I got a few minutes left here. I'll just go through and highlight a few of these. I've got on the last couple of pages some checklists for you about the common decision points that have to be made. So who are the team members? What are their levels of participation? So some teams started very large and are trying to define sector representation at the decision-making table. I think it's critical to agree on guiding principles and vision. Those are the touchstones you come back to. Designing that table of decision makers, determining how you'll engage those core players, defining the mandate and authority. So if these are CEO-led, some of these decisions will be within the scope of the CEOs or executive directors. Some might require board approval. And decision-making principles. And mostly we're seeing consensus, which means we may not all agree, but we can all live with it. And that then, of course, leads to robust dispute resolution mechanisms to ensure that we can keep everybody at the table and move forward. But so that's the most frequent model. I've got on the next slide just an example of some of the things that we're seeing within the mandates of some of these decision-making tables, so that ability to create various subcommittees. Very important to identify the priority areas for implementation, the target population for year one and for year two. Deal with all those engagement challenges that you have, and I know many have been very involved in that as they've come together and planned, and so have almost organically created some models for future engagement. You're required to identify how you'll add additional team members, and I think it's going to be important for that leadership group to determine how it will engage with the boards and facilitate board-to-board interaction to ensure that that develops, because that will enable the next wave, I think. And then I just say a couple of last words on slide, the next slide 14, before I just leave you with some of the more open questions. I think the most important point here is recognizing that it's really important when you do develop the patient care initiatives and you have a statement of work or a project charter, that you can be open there to engage team members who aren't on the core team. So thinking about other players that might play a role in that service delivery, that's a good way, I think, to begin to build the, as I said, underscore for the word team in team, but that's where I think you need to be concerned about due diligence. And those project charters may have their own term and termination and dispute resolution processes, and they may have their own governance model. So you may strike an overall committee to oversee that particular piece of work. So some of the last considerations just to leave you with, thinking about different levels of participation at different stages of development, adding team members, the role of the volunteer sector, impact on foundations. I know some foundations are beginning to think about that, what this might mean for foundations and fundraising down the road, and the implications of some of your team members who are participating in more than one OHT. Thank you.
Well, thank you so much, Anne. That was a whirlwind tour of a lot of rich and deep thinking and study and experience, both with OHTs and other collaborative governance arrangements that we've trialed here in Ontario. I think we just, that tour was really beneficial for me. Actually, I had a few questions while I was listening to Anne that I've written down. And if you, like me, have questions before, or while we're hearing from Terry, feel free to add them to the chat box. And when we get, after we hear from Terry, we'll have a lot of time for Q&A with Anne and Terry. So while you're doing that, if you did have a question that you thought of during Anne's helpful presentation, I'd like to introduce Terry Sparling, who, as I mentioned at the start, is the CEO of the Huron-Perth Centre for Children and Youth. This is the Huron-Perth Area Ontario Health Team, and as someone who grew up in southwestern Ontario, I'm very excited when we have teams from that area that are able to present and share their experiences thus far. Terry, we're really grateful for you to join us today and excited to hear more about how you've been tackling the collaborative governance challenge within the Huron-Perth Area OHT. So I'm going to turn it over to you now.
Thank you. I'm delighted to have a chance to do this. It's pretty exciting to be a small organization within a rural community that's responsible for child and youth mental health, and to have had the opportunity to be so intrinsically involved with the initiative. So I want to go back to the slide around the importance of good governance and a health system approach. I think there's a couple of things I'd like to highlight as we came together to form ours. It was an inclusive process to invite as many health-funded organizations and related sectors to come together, leading us to have 52 partnering organizations. At the heart of it, I would say there was a recognition that we wanted to respect the autonomy of individual organizations and presume competence. So to the point about needing organizations that already had good governance in place, we've started from the place that we believe that's already in place. So presumed competence is always a good way. Even in the early stages with doing our I've lost the language now, our self-discovery process and the self-assessment, we completed that self-assessment in one meeting, and out of that emerged a shared vision and shared commitments. We voted with thumbs up and thumbs down, and that has continued to be our easy way of gathering people as we've continued to along this journey. The notion of a shared vision and shared commitments, we view this to be iterative. We are already building on good working relationships across our two-county region, as well as our adjacent counties that oftentimes have patients that cross over and are in our area. In the process, we've had many new relationships built. There's a few that never knew there was a child and youth mental health center, and they now know that I have a lot to say. And it's also been an opportunity for established relationships that exist within each sector to continue to build on those things. You speak to the point about how do boards grapple with balancing the acting in the best interest of their individual organization's mission and the collective mission, and that's where we would say having a shared vision and goals and all of us embracing the end game and the outcomes we want to see is really where we're going to see us being able to stay together. I think we've tried hard to stay focused on what's in the best interest of the consumers who journey through the system. So the voice of patients, clients, caregivers has been recognized to be pretty significant. The other thing I guess I would want to jump on is there has been a strong recognition throughout the process that the leadership needs to come from our boards. So to your point of the structure where you have the coordinating committee kind of driving it, we flipped ours a bit, and we would say at the top would be partner boards that are coming together to provide direction to an implementation committee. We have valued all of the sectors that have come on board, which we represent a large, almost the entire aggregate population that we anticipate serving at maturity, lifespan, and at the same time recognizing that throughout the structures we absolutely need to have patient voice and physician and clinical leadership. So we've worked hard to embed that in all structures, recognizing that it's a challenge to move forward in the timelines that we've had. You know, the work started August 7th, and we are ramping up to next week. There are a couple of key perspectives, physicians and clinical leadership, that wouldn't have necessarily been organized in the same way to bring them together, and getting the voice of patients is always important, but again, not necessarily an organized group. So we've built space for that, and then time for people to get on board and understand what we're trying to create together. I'm just looking at a few other notes. To your point about a team within a team, we recognize that being a rural area that primarily encompasses our entire population almost at the starting point, that we have some relationships that are to our adjacent counties that will be important. So regional relationships, adjacent OHTs, that there may be crossover, and then specialties that might exist within Ontario Health Teams and us wanting to have our our patient population be able to benefit from those things. We have been a group that is not imagining that we will end up as a single entity. We continue to imagine that it will be our partner boards that will drive this even in the future, recognizing that we know the government wants a single funding accountability, but we think that's solvable through a memorandum of understanding. The notion of your chart that talks about single funding at the top and full continuum with coordinated and integrated service at the bottom. We think that that's what we've been striving for all along. Probably the single funding piece would be the biggest change. And there are some enablers that will help us with that. That will be the things that come with digital health, getting our physician leadership in place and helping to drive change, and a shared record will be key enablers. But taking it back to where we are today, the single biggest enabler is communication. We have been building, we can review pathways to communication. We're not perfect. There's some places where we could have done better. We just continue to build on that. Communication is key. If people understand where you're trying to drive to and that there's a place for them to join, it reduces the number of times where people will feel threatened and find it difficult to embrace shared outcomes.
So Terry, wow, that was a huge number of insights, and Anne and I were both shaking our heads, and both in terms of acknowledging a lot of the things that you were saying, but also we were highly impressed with what you've been able to do as a team so far in your region, and that's a large number of partners to have on board, and you know, working in the context of largely rural area. You know, it does mean that different organizations may have had quite different experiences providing services than some of the other teams in the province. And so it's really interesting to hear how you've approached governance in terms of thinking that the boards are sort of playing more of a leadership role than what Anne had suggested. Although certainly, again, this is the best part about it is there's no one-stop shop. There's no one way of doing things, and it really has to respond to the existing relationships in your communities amongst the organizations, and like you said, I think the communication being critical. So I'm wondering.
So before you open to questions, if I could just make two final remarks. It would be recognizing that we do believe, as part of our structure, that there needs to be an opportunity for organizations at the board level to come together and have board-to-board conversations. To achieve that in the short time frame between August 7th and October 9th, that's an aspirational goal, but there's a recognition that there's an important place for that. I think the other piece has been, again, stressing the need for communication pushed out right through to boards and staff, and so there's been lots of effort to do that. And as we've written, every section we've made sure that there has been cross-pollination between sectors and between leaders in sectors, and it's amazing to see how when you put together, let's say, little child and youth mental health and primary care and long-term care, how you come to actually see that there's some commonalities around challenges with system navigation, challenges with coordinated care, and the need for improved communication. So regardless of patient population, and we do have 3 priority populations we're targeting in year 1, we have some shared places where we want to grow. So that would just be added comments.
I love that you're coloring in the lines of what Anne was telling us and giving it a lot more life around, things that are important to you. And I suppose points of commonality, despite your different sectoral experiences, is probably quite critical in terms of that foundation building. So I'm conscious of the time, it being 12:43, and we wanted to leave lots of time for questions. And so I'm going to ask Carrie if we've received any, and maybe you can start us off.
Sure. So I can tell what a wonderful conversation this has had by kind of the tons of questions that are flowing through the chat boxes. So I'll start with one that has come in, and I think this is maybe start with Anne on this piece and then throw it over to Terry about how they've approached it. What is your early thinking around approaches with collaboration with the private sector partners, so with vendors, tech, care providers, et cetera?
So I think, well, we've always had some collaboration there, right? I mean, I think as they've been service providers to current health sector providers, they've often taken almost a partnering approach to solution solving. So I don't see why that should change. Whether they will be participants in the team in the same way others will be, probably not. But I do think it's important to be thinking about what are the kinds of decisions we want to make and who do we need at the table to make those decisions. And there could absolutely be a role for parties who may end up being service providers to teams. We have to manage the things around fair procurement processes and people having roles and designs that may advantage them. But I do think that you always have to start from who do I need to help make the right decisions. And I don't think you're always going to be confined to people who are just within the team.
Thank you, Anne. Terry, did you have anything to add there?
I would say I think it's going to depend in every service area. In our area, we've certainly focused more on publicly funded organizations, recognizing that every sector, because we have a number of them represented, they may well have working relationships or existing partnerships with for-profit or fee-for-service structures, and we wouldn't want to exclude anyone if, in fact, they could play a valuable role moving things forward. That's how I would answer that.
That's great. Carrie, back over to you.
Great. So the next question that I have is, how have you dealt with the significant power and resource differences between partners in some of these OHTs?
Well, great question. That, of course, as you know, is one of the biggest risk factors to collaborative governance. It fails when there's a disparity of resources between the parties. All I've been able to do when I've been at early stages and having conversations or doing some education around this, how to get started, is to talk about I think, the importance of coming together as equal partners. So in any integration or amalgamation that I have done over the years where we've had a large player and a smaller player, if one player thinks they're going to win at the end of the day just based on resources or number of employees or size of budgets, the negotiations are probably doomed to failure off the get-go. And so it has required, and you know, one of the biggest issues here has been a concern that hospitals are going to take it all over. And hospitals are very aware of that. And so the hospitals will say to me, people don't trust us because they think we'll take everybody over, and then smaller players say, oh, it's theirs. That's all gone. I'm not hearing that anymore. I think that was a fear at the beginning when there was a lack of understanding. And I think that this is where the guiding principles, I think, are important. That the principles of equal partners, equal voices, and really understanding what the consensus process means, what the risks are around a consensus process, and having strong dispute resolution mechanisms down the road. Those are more important down the road, but I think in the early planning stages, I think you have to recognize you're not getting anywhere unless everybody is engaged and everybody feels respected and valued.
I want to ask you this question as well, because coming from a child and youth serving agency who probably traditionally hasn't been the larger partner, I wondered if you could speak to how the power dynamics are playing out.
So I would say that I would be naive to say that there aren't any dynamics in existence, but I would say that the discussion around needing to build on trust, baby steps, respecting that every partner is equal has helped drive our governance model where every partner board has a voice, and that the physician and clinical leadership and patient voice is embedded in all of this. If you stay focused on those things, then number one, it doesn't matter how many partners you have, you're coming in with an equal vote. And if you are ensuring that you've got leadership from physicians and clinical leads as well as lived experience, then our work becomes clearer around how are we shaping change. We have had beginning conversations around how we might resource, because so far it has really been, for the most part, goodwill of those that can give in time or in some kind of in-kind contribution of staffing. And we would see the model would be some sort of formula driven that would recognize what resource an organization might be bringing to the table, and recognizing also that we have some organizations that are not fully funded, that many of them depend upon fundraised dollars in order to achieve their missions, and we wouldn't want to touch those fundraised dollars. So there's been some beginning thought in that as well.
That's super helpful. Carrie, next question.
Oh, sorry, I was having a little trouble with my mute button. Okay, so the next question is, sorry. The next question is, and I think this is probably a good one for Heather and for Terry. So Heather, maybe you can start with the answer of, what direction is being given where there are multiple OHTs in development in the service area of a single child and youth mental health service provider?
Sorry, can you ask that question again?
Yeah, I was just going to say the same thing, Terry.
Sorry. What direction is being given when there are multiple OHTs in development in the service area of a single child and youth mental health service provider?
Well, I wouldn't say that there is a direction as much as a field, we are closely connected to one another. Lead agencies for child and youth mental health meet monthly. There is active sharing back and forth around service area experience. I'm well aware of what's happening in other areas and had the opportunity to participate in a panel last week with Children's Mental Health Ontario. And so I'm aware, for instance, of Ottawa forming a child and youth mental health OHT. I would see that to be linked to my comment earlier around a team within a team. I will be delighted to be able to reach out to any area that might be forming a structure, whether that's as an Ontario Health team or whether that's as a separate body that collects child and youth mental health expertise, so that our area can benefit from their specialty focus on child and youth mental health. And I don't think that's exclusive to child and youth mental health. The other thing I guess I would say is that early in the go, in our area, we've already been at the table with adult mental health, and so being able to have a place within a lifespan model for mental health and addictions, we already had that work in place before we even did the self-assessment.
So I just add to this to say there's no direction given, but what I think is important to remember is that some of these smaller organizations, whether they be child and youth mental health, adult mental health, other small community providers, if they're interfacing because of their catchment areas with multiple teams, that's a real burden in terms of the ability to be a full participant in multiple teams simultaneously, given all of the heavy lifting that needs to happen. So, first, I think that in general, all teams need to acknowledge that if they have a player at their table who has a catchment area that spans multiple OHTs, that they might need to make some accommodations and consider involvement that's highly strategic and ensuring that they're there for the appropriate conversations so that they can participate in other conversations as well, and trying to, again, think about creative ways to allow participation using technology, et cetera, so that they can be part of decision making at crucial junctures, but maybe not be there for every single conversation. But that is, that only works if there's trust amongst partners. And so again, back to that trust building. And I think teams and also those smaller organizations are going to need to consider for their own selves where, what is the developmental trajectory of the various OHTs, understanding what they have planned in terms of decision making and conversations, and where they choose to want to put their efforts and expertise in terms of time, because time is our most valuable resource, and these small organizations don't have a lot of senior leaders that can participate. And I don't know if you were nodding, but you just agreeing, I think. Any other questions, Carrie, from your side?
Yeah, so do we still have time for maybe one more?
Oh, yeah, we're 12:53. We're good.
Oh, excellent. Okay, so I'm just going to flip the slide back to 16 because it relates, 22, because slide 16, sorry. Because it relates to one of the questions, one of the pieces on here. And the question is actually for Terry, whether she can elaborate a little bit about how her team has begun to address the point around kind of business plan and due diligence for each project.
Well, I would say that our biggest challenge has been that every sector already has some projects that then align with some of the 3 areas that we want to make some improvements on. And it's been a question of how might we actually pick which ones we would even showcase. The conversations have been lively as we've been ramping towards next week and submission, because the number of projects that are either already started or desired far exceed what one might accomplish in a given year. And there has been attention paid both to the project as well as taking the time that it takes to define what would be the metrics to measure our successes. And that, again, with an area of 52 partners and needing to have cross-sector contributions, particularly from physicians as well as patients, you simply need to have the time for that. So to your point about business plan, we would imagine that our first mission will be about getting an MOU in place based upon our initial conversations and sorting out some of the resourcing questions that need to be determined, because we do know you need some resources to move the work forward. And then I think we'll be using working groups and the priority groups along with some priority setting planning working groups to help us put the detail to a business plan.
Great.
One last point. We have had some good conversations around a decision-making clause for how we would move forward, because we are wanting it to be consensus-based. We are recognizing that the impacted sector must be in agreement for a decision to be finalized. We feel that will significantly reduce the number of areas where we would actually need to use a conflict resolution process. And to that point, I think a good part of it's going to be about building in sufficient process that then the sector that's going to be impacted would actually understand why we would want to pursue that change and then could embrace it.
Carrie, Anne I think wants to weigh in here for a second.
Yeah, just a brief comment. I wouldn't want to leave the impression that in every initiative you undertake, you might need some broad scope of due diligence or even a project agreement. So it may be some things you identify simply require one organization to do something differently and another to do something differently, and there is an improvement of itself. But others may require some commingling of resources or assets or transfer of services or resources, and that's where you may, if employees are transferring, if assets are transferring, then you're going to have to do more of a business plan around that. So I think it'll be a continuum of implementation models as well. I just simply felt it would be wrong of me not to address that there might be a good scope on some of these and a much smaller scope on others.
Mm-hmm. Yeah, so if you're going to do some of that work around developing care pathways where multiple sectors might be implicated doing different things and needing to work differently together, then maybe that's an example of somewhere where you might do a little bit more formal planning around developing a business plan, et cetera. Carrie, we could probably squeak in one more quick question. On mute. Okay, so I'm going to close this off then since, you're back. Did you have one more question?
Yeah, I thought my mute was off. It was on. So there is one more question here, which is, who should be responsible for recruiting project management resources? Are they expected to be in kind?
So I don't think, again, that there has been any direction around resource, either human or financial, with respect to this stage of the OHT's development from the government. And so, I don't know that there's an official party line on that front. I mean, I think we can, Terry, you might be able to speak to how you've managed the OHT work in here in Perth, and then maybe Anne can weigh in just from her understanding of what some of the other teams have been doing on that front.
I would say that from our area, we would be looking to bring together partner boards and that we would be needing to populate the implementation committee through a process that every sector would follow the same process. We need the leaders in place, and then we'd be able to start moving forward in terms of detail. The resource conversations we've had up until now will have included a conversation of what do we need before we start worrying about what's going to pay for it. So we're not imagining it's going to be one organization that's making the decision or taking the lead. We would see that the structures that we've already got going to even pull off this application are going to help us move to get the implementation committee in place, which would be co-led by the patient partner and an independent community appointee.
That's a fantastic insight, Terry, and how you're prioritizing the work and then trying to sort out, secondly, who is going to be in a position to help and who you're engaging those decisions. And did you have anything else to add?
I don't have much to add to that other than what I'm seeing is that the parties, this is a decision the parties have to make, whether they use internal resources that they second over and how they agree to cost share around that, or whether they partner around hiring external support that becomes an employee of one and second to the others. I think it's really open. I don't see any one specific pattern emerging, and I think it's very contextual.
Thank you so much. So with that, I'm going to close our webinar for today. I flipped the slide that says related resources there just to let you know what we have on the RISE site and what we have linked to on the RISE site in terms of resources. BLG actually, so we've posted a link to the most recent resource that they've created, but that's your fourth, right?
Yes.
So there are multiple resources on the BLG site that are freely available that you're welcome to take a look at, where you can benefit more from Anne and her colleagues and their thinking on this. I want to just let you know again that this is the last webinar in the series. We will get the recording up later this week. Please need to keep an eye out for our next round of events and resources, and sign up for our newsletter, and please join the community of practice and tell us what you need, what is helpful on your journey, and we'll do our best to respond. So with that, I really want to thank both of our panelists, Anne and Terry, you have just provided so many insights in such a short period of time on this topic. I know it's getting the wheels turning, even though they've already been turning for everybody who's taking this journey toward being a full OHT. So thank you so much for doing this on short notice and making yourselves available to participate with us. We really appreciate it. And everybody have a nice afternoon.
Thanks so much.
Thank you.